Initially, the topic given to me is the TMVR, but actually we don't have much experience on TMVR in native valve. So I give the talk entitled In Failed Surgical Mitral Bioprosthesis. As we know, dysfunction of a bioprosthetic valve replacement is a well-known entity that occurs with saver and taper valves. Up to 15 years, the incidence will be as high as 60%. So transcatheter valve-in-valve for failed surgical bioprosthesis means that to use a transcatheter heart valve in the mitral position. Valve-in-valve was performed in failed surgical bioprosthetic valve, and the mitral valve-in-ring is performed in failed surgical annuloplastic ring. According to the literature, valve-in-valve TMVR is associated with lower mortality and morbidity versus redo surgery, and a temporal shift toward the increased use of valve-in-valve TMVR was observed. From the largest or landmark study of mitral valve 5-year result, it is shown that transcatheter mitral valve replacement in ring or valve or mark were associated with sustained improvement of heart failure symptoms and the quality of life among survivors at 5 years. Transcatheter heart valve function remains stable in all 3 groups. However, as you can see in the survival curve, patients treated with mitral valve-in-valve had excellent survival at 5 years, whereas survival was lower in the mitral valve-in-ring and the mitral valve-in-mark group, consistent with underlying disease severity. In STS and the ACC DVT registry, showing that mitral valve-in ring, the data showing that the technical failure rate was really high comparing to valve-in-valve. It was 12%. And 1 year all-cause mortality was 22%. However, if the technical failed, the 1 year survival rate were even worse, up to 31%. So there are some major issues in doing mitral valve-in-valve and the mitral valve-in-ring. The main issue would be the LV outflow tract obstruction. This is a major complication. The incidence is highest following valve implantation in mitral annular calcification, but sometimes observed following mitral valve-in-ring or mitral valve-in-valve procedures. The mechanism of LVOT obstruction in mitral intervention, including fixed obstruction, which occurs when the anterior mitral leaflet is pushing toward the interventricular septum by mitral valve processes, creating a narrowed and elongated near LVOT. The other mechanism is dynamic obstruction, occurs when the narrowed near LVOT generates Bernoulli forces that draw the anterior mitral leaflet toward the interventricular septum during systole. So a long anterior mitral leaflet is a risk factor. The possibility of LVOT in mitral valve-in-valve was around 0.7% because the anterior mitral leaflet had been excised during the surgery. So only the strut and the interaction between the interventricular septum. However, in those patients with preserved anterior mitral leaflet, fixed and dynamic obstruction risk is higher, may up to 4.5%. So imaging evaluation of the risk of LVOT is of paramount importance in pre-procedure planning. We should measure the predict near LVOT to evaluate the risk of fixed LVOT and evaluate or measure the anterior mitral leaflet length to estimate the risk of dynamic LVOT. Other parameters such as outer mitral angle and the septal bulge can also be evaluated from the procedure CT images. Nowadays, we can measure frame near LVOTO and the skirt near LVOTO. If the measured number is smaller than 200, the risk of LVOTO will be increased. Usually, we start from the remeasurement of the transcatheter HAVA, structure HAVA dimensions of the surgical HAVA to measure the dimensions. And also from CT projections, we can see the configuration of the surgical valve. And then we match the finding to the app to find the configuration of the surgical valve and the true inner diameters. There is some difference I have to mention for the surgical valve. The stem frame of pericardial valves are taller than porcine biprosthetic mitral valve. So if it is a porcine leaflet, it will be shorter and provide less cover of the transcatheter HAVA stent frame. This translates into less risk of LVOTO with porcine surgical heart valve. However, when the transcatheter heart valve is implanted within a bovine pericardial leaflet, the leaflets are pushed outward but cover the whole stent, so the risk of VOTO would be much higher. So when we measure the surgical biprosthetic ring, there are many kinds of surgical ring being used. So you can measure the diameter of the ring. However, only those patients with a complete but semi-rigid ring would be good candidate for mitral valving ring procedure. Then we will simulate the balloon expandable transcatheter heart valve inside the surgical ring to measure the near LVOT area. As I mentioned before, the outer mitral angle and the strut to septum distance are important risk factors for estimation of LVOTO. So this can be done pre-procedurally through the CT measurement. And in those patients with a long anterior mitral leaflet in mitral valving ring scenario, if the anterior mitral leaflet length is longer than 25 millimeter, the risk of LVOTO will be increased. So putting them all together, the risk of LVOTO are multifactorial. The near LVOT area, anterior outer mitral angle, strut to septum distance, small LV cavity, septal bulge, or long anterior mitral leaflet length are all risk factors. These factors can work in combination to cause dynamic LVOTO, especially if the patient have a residual long anterior mitral leaflet. Encounter this patient or like dynamic LVOTO, the option to prevent LVOTO is to do LaPoon procedure. For those with septal bulge, another leaflet issue, then alcohol ablation may be needed. So the so-called LaPoon procedure is to intentional lacerate the anterior mitral leaflet to prevent LVOTO. This can be done through a base-to-tip approach, but it is time tedious. In our center, if the patient is a surgical ring or surgical valve, then we will do tip-to-base LaPoon. Tip-to-base LaPoon can be done using the corin wire to lacerate cauterize the anterior mitral leaf in the mid, and this can split the anterior mitral leaf and then prevent LVOTO. In our center, we have a modified protocol to do that. We omit some unnecessary procedure, and we use rendezvous technique with 2 guiding caster to protect the wire from injury to the surrounding tissues. We use low energy, and we use a brain protection device. In this way, we can do a safer LaPointe procedure. This is what we have done with the use of 2 guiding casters meet to each other, and they close up and becomes a tunnel. Then the acetal wire can thread all the way to form a AV loop. Then we pull the 2 guiding casters from aortic and atrial side. Then the wire can be cauterized and cut the anterior leaflet successfully. This is what it happened during laceration of the anterior mitral leaf. That if the procedure was successful, okay, the movie doesn't move, you will see a new mitral regurgitation after the successful cutting, and you can appreciate the cuts or the split of the anterior mitral leaf by T very clearly. This is from the ventricular side, and this figure, I don't know why the movie doesn't work, but you can see very clearly the new mitral regurgitation. Oh, and then you can appreciate the leaflet being cut and the jet in the LVOT without obstruction. So all this can be done by intraoperative T monitoring. Up to now, we have done more than 20. This is what we have summarized in this year's Euro PCR, showing that our 15 earlier cases. As you can see, no LVOT obstruction after the LaPointe procedure. The mean LVOT pressure gradient was only 5.9 millimeter mercury. In 2 cases of mitral valve in ring, we need a second valve because of first valve got a severe paralysis. And it is interesting to note that when we use a LaPointe procedure, in those patients with even with a near LVOT of more than 100 to 200, there has been no increase in LVOT gradient. Only those patients with near LVOT below 100, the gradient will come up. Furthermore, I have to mention this is a complex procedure, and during cauterization, you can cut many debris by the cerebral protection device during procedure. However, if the procedure was successful, so as you can see, the gradient significantly reduced and the functional status improved. Comparing to the mitral trial, at 18 months follow-up, our outcome was significantly better than the mitral trial. That means actually in every case with mitral valve in ring, we did LaPointe. So this can significantly improve the outcomes of mitral valve in valve and mitral valve in ring. So transcatheter mitral valve in valve, mitral valve replacement using a balloon expandable platform infer the surgical bioprosthetic valve or surgical annuloplastic ring are increasingly being used. The clinical outcomes have improved over the years. Unique challenges remain, such as the risk of LV obstruction. However, pre-procedure planning and imaging evaluation and adjunctive procedures such as LaPointe procedure may mitigate the risk of VOTO in high-risk patients, improve outcomes, and benefit more patients with borderline near LVOT. I thank you for your attention.